What's the difference between being lightheaded and vertiginous? The patient was admitted with dizziness. Well, patients don't say vertigo, patients say dizziness. But doctors shouldn't say dizziness. So what do you mean they were admitted with dizziness? Did you mean vertigo? Or did you mean lightheadedness? Because lightheadedness is an arrhythmia. Lightheadedness is aortic stenosis. Lightheadedness can be mitral stenosis, HOCM, aortic stenosis, hypotension, bradycardia. Those are all the things I just saw this week as a telemetry attending. But one of those patients was there simply with vertigo. She said, yes, the room was spinning around me. And I felt nauseous, and I felt no different when I sat down. It wasn't positional. And I said, look at my finger, look at my finger, look at my finger, look at my finger. Because everybody who thinks the world is spinning around, their eyeballs are trying to catch up, and their eyeballs are going thinky, 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 thinky. So everybody with vertigo has nystagmus as the world is trying to catch up with your eyes. Now, why is it benign positional vertigo? Because it's not associated with anything evil. Why is it benign? Because it gets better. Why is it benign? Because it's got no hearing loss. Why is it benign? Because there's no tumor that you're going to find on an MRI of your internal auditory canal. Why is it benign? Because it generally doesn't recur, and even if it doesn't recur, it doesn't get worse. Why is it benign? Because we don't have to ablate your ear like we do in Meniere's. Why is it benign? Because you might not get you're not going to get permanent hearing loss like in labyrinthitis. Why is it benign? Because there's no ringing in your ears. Now, ringing in your ears sounds to the average person like an inconvenience. But if you heard this sound, for the rest of your life, it wouldn't be so benign. I love you. What? I love you. What? I can't hear you. The rings here. My ears are ringing. So tinnitus is not benign. Tinnitus bad. Blocks other sounds. Ataxia, acoustic neuroma. So you're going to master vertigo with Master the Boards and me. And what's different about this one is that labyrinthitis doesn't change or come on with the change in position. And labyrinthitis doesn't need any specific, labyrinthitis does not get you to where you're going to sit up and suddenly start vomiting like crazy. And acoustic neuroma is not acoustic neuroma only when you change position. And Meniere's disease doesn't change with position. And Perilymph Fistula doesn't change with position. And that is what's different. This is the only one that gets worse when you try and sit up, because the otoliths, your ear stones. How do you sense yourself at those semicircular canals? Because when you move, the fluid moves in them. How does the fluid move? If it's a filled container, because there's otoliths that move and provide fluid movement because the rocks in your ears move. Now, there are two maneuvers in benign positional vertigo that are very complicated, and we have never suggested that you learn a lot of the details of how to do them, because we don't feel that they're worth the energy investment of time to get the few questions right that you need to know, because you're not going to be doing these maneuvers yourself. So there's one maneuver as a diagnostic test of positioning the head and moving it around and looking for the direction of the nystagmus and trying to twist their head off. And there's another maneuver, the Epley Maneuver, which is a treatment. A repositioning treatment is the Epley Maneuver. So there's two maneuvers. Dix-Hallpike, named after a dude, two dudes, Dix and Hallpike, diagnose it. And Epley repositions those otoliths. What's the most common wrong answer in benign positional vertigo? Is the treatment. The most common wrong answer is saying that meclizine will help. Meclizine's not going to do very much. Meclizine is an antihistamine specifically for the production of endolymph in your ear. So meclizine tries to decrease the production of endolymph in your ear and decrease the sort of hypertension, sort of ear CHF. So it doesn't work for benign positional vertigo because benign positional vertigo is a physical abnormality in the positions of otoliths that need to be physically repositioned. And as you can see here, you shouldn't be trying this at home, kids. What's the difference between that and vestibular neuritis? Well, vestibular neuritis is an inflammation. It's like Bell's palsy of your vestibular system. Now, the eighth cranial nerve, you may recall, is divided up into two parts. There's the vestibular part that senses your position in the world, the semicircular canals that tells you where you are, am I up, am I down? And there's the cochlear part that goes in and transmits sounds. Now, vestibular neuritis is an inflammation. It's like optic neuritis of your eighth cranial nerve, but only the vestibular portion. And since it's only the vestibular portion, you're not losing hearing and you're not having abnormal hearing. But the difference is that just like in Bell's palsy, we think it's viral. Antivirals don't work, but we think it's a viral condition. You get vertigo, and since you get vertigo, everybody that has vertigo gets nystagmus because you're spinning up with the world. And the vertigo and the nystagmus is dizziness. And only one of them is related to position, and that's benign positional vertigo. Now, there's no specific test for vestibular neuritis the same way there's no specific test for Bell's palsy, is there? There's nothing to physically see. And the treatment here, we give meclizine as some symptomatic relief because the steroids don't work well for this, and there's nothing else we really can do for this. There's nothing to operate on. It's an abnormality of the perceptions coming in from the semicircular canal, from the cupula, and here is a gyroscope in your ear. This is the cochlear portion. The cochlear portion that looks like a labyrinth. Now, labyrinths were developed, well, there are labyrinths in ancient history, there are labyrinths that the Mayans had, and labyrinths were a very, very common feature of the Gothic cathedral. So when you have an inflammation of the vestibular portion, you have nystagmus and vertigo without hearing loss, without ataxia. When you have an inflammation of the cochlear portion is the hearing portion. And the cochlear portion also goes with tinnitus. Now, what's the difference between this and Meniere's disease? Because this is very similar to Meniere's disease, and the answer is Meniere's disease is chronic and recurrent and gets so bad with the tinnitus all the time that a patient will say to you, "Doc, I'd rather be deaf in that ear than have to have that ringing in my ears, which is driving me crazy." And that's what happens in Meniere's disease if it doesn't get better. Labyrinthitis is self-limited, but what do you do for a person who has optic neuritis, sudden loss of vision, or losing parts of vision? What do you do for Bell's palsy? Now, meclizine is okay for symptomatic relief, not for benign positional vertigo because that is stones. So labyrinthitis is Bell's palsy of your ear. Bell's palsy is labyrinthitis of your face. Optic neuritis is Bell's palsy of your eyeball. So Bell's palsy, seventh cranial nerve palsy, optic neuritis, labyrinthitis, which can all result in permanent loss of vision, hearing, and facial movement. Boom! Run to give steroids. If you get that one thing out of this section, you're going to get a lot, because this is the one people forget about and people go deaf. So that's why I want you to relate to Step 3 USMLE, Level 3 of COMLEX as deeply good. If you see this as just some other scary exam that you're going to be judged on, or a pain in the ass that I just have to get through, but then you'll still do it, but it's not going to have as much deep sense of joy, satisfaction, and accomplishment as you might be the only person on the team that says, "Hey, what about using steroids for that sudden hearing loss?" Or is it just such a small thing to go deaf in one ear? It might be you. Maybe you are the one you've been waiting for. Now, Steroids can stop acute hearing loss. These are Tibetan monks, but they're in a Cistercian monastery and near Gothic cathedrals. And they are Tibetan monks walking the labyrinth as a meditative practice. Save hearing. Protect people from suffering. You see, the Tibetans say, as long as space and time endure, as long as sentient beings exist, there shall we abide to dispel the suffering of the world. Meniere's disease, like labyrinthitis, it just goes on for a really long time. You get the vertigo, hearing loss, and tinnitus, except it's chronic and recurrent. And what you try and do is you use sodium restriction and diuretics, because it's like ear CHF. Sodium restriction and diuretics because you're trying to be able to decrease the amount of fluid. There's excess endolymph and perilymph in the inner ear. And then when you can't control it, you actually get it ablated. You get gentamicin, which is ototoxic, shot into the ear, because as I said, if you have that tinnitus, it's so uncomfortable for people that people would rather go deaf in the ear. Now, what's different about acoustic neuroma? Well, the whole section is on dizziness and vertigo. Everything that gives you a sense of vertigo will give you nystagmus. Anything that gives you vertigo and nystagmus and tinnitus is going to give you nausea and vomiting. So what's the difference? Well, what's that pain in your foot when certain people wear overly tight shoes and they get pain in between the second and third toe? That's called a Morton's neuroma. Now, Morton's neuroma is an excess thickening of a peripheral nerve. This is an excess thickening of a cranial nerve, which can happen just by happening. It can happen from neurofibromatosis, but it's like Morton's neuroma of your 8th cranial nerve. And here's the big key word. What's different about acoustic neuroma is it sends abnormal signals, so it gives you some ataxia on your exam. So you see, we've tried to give you something that's different about each of them so you can answer what's the most likely diagnosis. The other point is, in all of these causes of acute problems with vertigo and nystagmus, and all these problems when it gives you hearing loss now, this is the reason why almost all acute hearing loss and tinnitus should get a scan. What kind of scan? MRI is better. MRI is better because it can see smaller things. Now, the reason to know about this is that if you don't specifically say, I want an MRI of the internal auditory canal, you won't get the special thin cuts like this, carpaccio. Carpaccio, what is carpaccio? Little thin slices of beef that if you don't say, I want little thin slices from the internal auditory canal, you won't see it. And just like a ganglion cyst on a tendon or a nerve, and just like any other neuroma, you have to slice it off to physically relieve the pressure. Perilymph fistula is the stapes. There's 3 bones of the middle ear, the incus, the malleus, and the stapes. And when you get perilymph fistula, when all of a sudden you see this, boom! And then the stapes got shot through the oval window. And when the oval window gets smashed, that barotrauma makes the perilymph and the endolymph leak out. And it leaks out and gives you a sense of hearing when there's no sound. It gives you a sense of movement when there's no movement, because hearing and movement are detected by the motion of that liquid in your inner ear. And the only way to fix it is surgically. For every person who gets killed in an explosion, in a bomb, when people decide that for whatever their reasons are, they've got to go kill other human beings with bombs. For every person killed, the most common injury is not a flailed chest, it's hearing loss, deafness. For every person who gets killed, 10 go deaf. And the only way to get it better is with surgery, because you need to have a physical closure of the hole. So let's summarize what we've seen here with vertigo. All forms of vertigo give you nystagmus because you're spinning around the world. and the world is felt to be spinning around you. Only one of them changes with position. Benign positional vertigo is the only one that changes with position. No hearing loss and tinnitus. Vestibular neuritis is not affecting the cochlear portion. Since it's not affecting the cochlear portion, you get no hearing loss and no tinnitus. Labyrinthitis is acute hearing loss. Remember to give the steroids so that you can prevent them from going permanently deaf in that ear. Meniere's disease is like labyrinthitis, but it's chronic, recurrent, and you may get better with salt restriction and diuretics, and you may have to get the ear ablated to get rid of that terrible, terrible sound. Acoustic neuroma is the only one with ataxia. If you're not thinking about it, you won't get the thin slices. That's why all acute onset of hearing loss, unilateral hearing loss, needs a scan of the internal auditory canal. All acute, unilateral hearing loss. You exclude the acoustic neuroma, then maybe you say it's labyrinthitis. Look for the history of the barotrauma of the bombs to suggest the perilymph fistula, and that's what will help you to know that you need to do a surgical repair of the oval window. Now, Wernicke-Korsakoff, why is it going in here? It's going in here because there's ataxia. It's going in here because there's ataxia and there's ocular problems that go along with this. And plus, where else does it fit? Who knows? Now, confabulation is not the same thing as delirium. Delirium is confabulation has more to do with why wet footballs don't fly and helicopters often eat their children. Is it hotter in Chicago or is it hotter in July? 'Twas brillig in the slivy toves did guide and gimble in the wave, and the Jabberwock went all snicker-snack with his mighty vorpal blade. That's confabulation. The individual words most often can sound normal. Why is it that wet footballs don't fly? Why do helicopters eat their children? It's a word salad, confabulation. Okay, confabulation, gaze palsies, ataxia, confabulation, and gaze palsies. And that's why, because it's here in the nystagmus section. So there's no specific test. You're using a head CT to exclude other things. You're using a head CT to exclude a stroke. Using B12 levels, because B12 can give you anything. You're excluding syphilis, excluding hypothyroidism. Kind of looks like most of the things that you do to exclude dementia, right? Yeah. So you can just put that in the same place as your brain, is that Wernicke-Korsakoff is a diagnosis of exclusion, and the treatment is very easy. You give people thiamine, and we ask you the same silly question all the time, which is more important? It's more important to give the thiamine first, then the glucose. Vertigo and nystagmus can seem very, very complicated to medical students, but here it is that when you're an intern, you're finally going to master it. And also, if you look at this as deeply good, if it's just step 3, the pain in the ass, you still have to go through it. But this, I hope, will make it much more satisfying. And that is deeply good. Good, true, beautiful, and one.